Good evening from University of Michigan campus in Ann Arbor. Truly a pleasure to be here. I will give you some perspective from the other part of the Atlantic on the diagnosis of diabetic peripheral neuropathy and also tips on differential diagnosis for the busy clinicians. And here are my disclosures. To set the stage, I like to put in the context these very serious complications, which unfortunately, at least in many parts of the US, continues to be overlooked in clinical practice. And to do that, I like to remind you that couple of years ago, with the American Diabetes Association, we had the opportunity to bring an esteemed group of experts from both sides of the Atlantic, US and Europe, and gather all the evidence with respect to diabetic neuropathies in this American Diabetes Association consensus statement on neuropathy. And that is highlighted in this slide. As you can see, there are multiple forms of diabetic neuropathies, with by far the distal symmetrical polyneuropathy or DPN, and autonomic neuropathies highlighted in rare being by far the most prevalent and most studied. And this is actually very strong evidence that we have acquired by having the opportunity to truly look at large and diverse cohorts of people with both type 1 and type 2 diabetes. And as Professor Valenzi has alluded to, indeed, we have demonstrated that truly this is a very prevalent and serious complication. And having the opportunity to look at this cohort, like type 1 diabetes, for instance, if we put together the diabetes control and complication trials, epidemiology of diabetes intervention and complication, or DCCT, the T1D exchange, the Scottish register here in Europe, the Swedish register, we have data that comprises more than 10,000 people with type 1 diabetes that had been phenotyped for both peripheral and autonomic neuropathy. And as far as type 2 diabetes, truly phenotype for neuropathy more than 30,000. And as Professor Valenzi has highlighted, these numbers are pretty high, up to 30%, DPN in type 1, up to 40%, autonomic neuropathy in type 1, including phenotyping with the gold standard cardiovascular autonomic testing, and then 50 and 60% of those with type 2. But what is also very important, we also had the opportunity to directly look at youth, children, and adolescents with type 1 and type 2 diabetes that we actually included. It's a large cohort. The SURGE trial includes more than 6,000 youth with type 1 and type 2 diabetes that were phenotyped for other complication, kidney disease, retinopathy, and then we were able to include the neuropathy evaluations and learn very staggering numbers here. 20% of youth develop peripheral and autonomic neuropathy, particularly those kids and youth with type 2 diabetes. So, and as it has been also alluded, food problems are huge, as 80% of people who develop these devastating food complications have neuropathy. And then, of course, the consequences are pretty important, from the loss of sensation, balance, falls, daily function, pain, ulcers, amputation, and death. Knowing that, in fact, peripheral neuropathy and amputation have very high risk of deaths. And with that, when one thinks about the diagnosis, and particularly the differential diagnosis of neuropathy, one needs to understand the anatomy of the peripheral nervous system. And here it's very briefly: large myelinated, small myelinated, unmyelinated fibers. You've seen this probably many times. We also know that in diabetes there is this progressive damage and loss of these nerve fibers that start with the smallest unmyelinated fibers, but then progresses through all these nerve fibers, which is also specific for diabetes. And it's an important clue for differential is this typical symmetrical distal to proximal loss of these nerve fibers. And when one needs to understand the diagnostic steps, including differential, one needs to remember that each of these nerve fibers have very specific roles and function, with these small myelinated and unmyelinated fibers being responsible for nociception, including pain and temperature and protective sensation. And the symptom that dominates the clinical scenario is this burning, lancinating pain, electric shocks, including hyperalgesia and allodynia, very specific forms of painful sensation that can be experienced even at contact with non-painful stimuli. And one can indeed highlight and unveil this dysfunction of the smallest fiber by assessing this thermal discrimination for hot and cold temperature and pinprick sensations, and there are a variety of methods available to do so. The large myelinated fibers are responsible mainly for pressure and balance, and people may experience numbness, tingling, and in more advanced stages, due to this progressive loss, they will have problems with balance that can then lead to falls and fractures and inability to engage in daily function. And the large fibers are best unveiled by looking at the vibration perception, threshold proprioception, ankle reflexes, as well as the light touch response to the 10-gram monofilament. However, I'd like to highlight, and that has been also discussed in the statement and in our clinical care recommendation, that there are differences in when one uses the 10-gram monofilament to highlight the presence of large fiber dysfunction versus understanding areas of severe callus formation that may mask underneath diabetic foot ulcers, and also that the loss of this monofilament is really a very late form of neuropathy, and therefore additional strategies have to be employed to proactively diagnose neuropathy more early in the course of the disease. There are several electrophysiology techniques and technologies that are available, including the one that Paul has discussed with you. But at least for United States, as well as Canada, where we do have a very different system than it is in Europe. In fact, none of these technologies are recommended because they do not provide a cost-effective care. They are expensive. They require waiting times for people to be scheduled to have these techniques. And in reality, one, at least with the data that we have so far, would not change the way that we would apply standard of care based on any of these techniques. Because in reality, with an array of instruments that one can carry in their pocket, when we examine patients in our office, one can easily assess pinprick sensation, to assess small fiber, vibration sensation, ankle reflexes, as well as monofilament, understanding, of course, that combining at least two examinations would increase the sensitivity and the specificity, particularly when unveiling this very specific symmetrical distal to proximal pattern. But again, I'm talking here about clinical care. In research is a completely different story. We do have a very high battery of research tools, including these various electrophysiological equipment and technologies, as well as small fiber specific measures such as the skin biopsies or the corneal confocal microscopy that I'm sure that Professor Malik will discuss in depth. Based on this clinical and symptoms, a variety of screening instruments to diagnose neuropathy have been developed, including the Michigan Neuropathy Screening Instrument, the Toronto Clinical Score, and Neuropathy Disability Scores. And I'm highlighting these three because these instruments have been the most broadly used when we look at population and cohorts. Again, when we have 10,000 or 15,000 people that we want to screen, performing a very expensive electrophysiology, it's not feasible. And thus understanding how to use this clinical and symptom-based questionnaire, it's very important to do population studies and clinical care implementation studies. I'd like to highlight also that many other forms of peripheral neuropathy exist. And it's also very possible that people with diabetes could develop either a different form of neuropathy or to have concomitantly both diabetic neuropathy and another form. And among these various peripheral neuropathies, here in this table that has been recently published as part of our most recent initiative with the American Diabetes Association, which is the ADA Neuropathy Compendium, just published a few weeks ago, are the metabolic diseases that are relevant for people with diabetes, particularly thyroid dysfunction and renal dysfunction, the inflammatory diseases, and I like to highlight the chronic inflammatory demyelinating polyradiculoneuropathy, as this entity, in fact, can have very similar feature, but has a very acute onset, very rapid, in fact, progressing in a patients that should then raise the suspicion. There are, of course, a variety of drugs, and we don't need to mention chemotherapy here necessarily, because by far among these various toxic substances, alcohol continues to remain one of the most important cause of peripheral neuropathy throughout the world. And specifically for people with type 2 diabetes, I like to highlight the vitamin B12 deficiency. And why is that? Is because still metformin remains the first line of treatment for people with type 2 diabetes worldwide. It is, of course, a very safe and studied medication. But as we have learned, after we have done the diabetes prevention study, and I think that you are all very familiar with the DPP diabetes prevention program that randomized people with pre-diabetes to either lifestyle intervention, metformin, and initially triglyceride that has been stopped, we've learned how effective lifestyle interventions are, about 60% reduction in the risk of developing diabetes, with metformin actually being quite effective as well. The other thing that we have done, that we were able to follow this DPP cohort now for almost 20 years. And during that follow-up, it has emerged that approximately 15 to 20% of people treated with metformin may develop vitamin B12 deficiency. And that is why in US, we have updated the standard of care and we screen for B12 deficiency in people with type 2 diabetes treated with metformin, because this indeed can mimic almost entirely the neuropathy due to diabetes, but it can be treatable with simple vitamin B12 supplementation. So what I like to highlight is that non-diabetic neuropathy may be present in people with diabetes and may be treatable by specific measures. And to end this talk, I just wanted to show you a clinical case of one of the patients that came to my clinic. And this is a 60-year-old patient that suffers from type 2 diabetes with at least 10 years of known history, has many other complications, as you can see. And he presented with severe burning pain in both feet that was ongoing for several months. He had new medication prescribed. He also had not noted any improvement at pins and needles, as well as nausea, fullness, and vomiting. Here is the physical examination, a typical type 2 person with abdominal obesity, and his medications at the time, including combinations of oral and injectable agents to treat hyperglycemia, as well as ACE inhibitor, diuretics, and statins, and then the new medication that was added for pain. Here are the initial laboratory testing that were available, and I'm sorry, I know that in Europe you use millimole, we use milligrams per deciliter, and I didn't realize that I should convert. But definitely the A1C is elevated, and in addition, he does have some features of metabolic syndrome with high triglycerides and low HDL cholesterol, which also have been clearly shown to be important risk factor for neuropathy. So in your office, if you would see such a person, what would you do next? And I understand now from Professor Ariel that questions cannot be answered as we speak. So anyway, here are the questions. Would you refer to neurology? Would you perform a focused neurological exam, assess light touch or B12 and serum electrophoresis, for instance? And because we cannot have the answers, I guess I will just highlight some of the key messages that we discussed about, that in reality one can assess neuropathy in the office. And initially, before referring for expensive testing that may not be needed, focusing on neurological exam in the office, and also checking B12 and serum immunoelectrophoresis would be very important initial diagnostic steps. And with that, I'd like to end by, again, showing you all this algorithm that we have put together for diagnosis and differential in the ADA monograph, that it's available to everybody should you be interested to have it, and to thank you for your attention, as well, of course, my collaborator here in US and throughout the world. Thank you very much.